Good morning and welcome to this edition of Navident Unplugged. Today the guest is Dr. Bradley DeGroot of Chicago, Illinois. Good morning, Bradley. How are you?
I'm very well. Good morning, Ken. How are you?
I'm great, thank you. And we're honored to have you here. It's a privilege. Dr. DeGroot will be speaking on utilizing dynamic navigation for the aesthetics and cosmetics / of anterior implants. What we're going to do today in Navident Unplugged is Dr. DeGroot is actually going to present a case to us, a case that he will be presenting, one of the many. And that's what's about to happen. So we're all looking forward to it, Bradley. So illuminate us, if you will.
Well, thank you. The case that I'm going to present today is one that really speaks to why we use navigation in our practice. All implants need to be placed accurately, but especially in the anterior maxilla, right in the smile zone, having an implant a 0.5 millimeter one way, a 0.5 millimeter too shallow. I mean, those are small numbers, but they can significantly affect the outcome. And so if we're looking for maximum aesthetics, if we're looking for something that's going to last the patient as long as possible, we need to make sure the implants are in the right place. And so the case I'm going to talk about today shows our ability to do that. And I think showcases one thing that really in our practice differentiates navigation from guided surgery. And I'll talk a little bit about that as we go. So this is our patient, showed up to this after a traumatic incident, a bicycle accident, had avulsed or cracked off the coronal about half of tooth number 8 and had chipped a number of the other teeth. So we saw him in our office on one day, and as you can see from this picture, things are a little beat up. We don't have a great landmark, but we were able to get him over to one of our restorative colleagues, and then very next day, that colleague was able to bond teeth in place that the patient was more or less happy with. Obviously not a good final product, but as far as the shape, we now have a shape, we now have a goal that we're going for. So this patient was then seen in our office. We made a 3-dimensional scan and uploaded that into Navident. And you can see in this picture, once it's imported, we can actually see the shape of the tooth. We can see exactly where the free gingival margin needs to be, and we can see all of that relative to the bone and the residual ridge. And so from that, we can then make all the measurements that we really need to make. We want the implant exactly 3 millimeters below the free gingival margin. We want the implant ideally at least 2 millimeters from the buccal ridge. I'm going to talk a little bit during the full presentation about why those numbers are important, but we can plan exactly where we want the implant in Navident, and then it's a very easy conversion. So the patient then went to surgery. We're able to place the implant within the socket, keeping everything very minimally invasive. In this case, because it's such an aesthetic case, we also made a temporary or a custom healing abutment. The reason I do this is to hold onto the papilla, to hold onto the midfacial tissue. You know, if we've got it at the time of extraction, it's much better, it's much easier to maintain it than it is to lose it. One of the things I kind of like to show here is you can tell that the implant's in the correct position already. And you can tell that by the emergence and how smooth that custom healing abutment comes off our analog there. And so the day of the surgery, the patient leaves with this healing impression in. We're able to rebond the tooth and then let everything heal. And you can see on the right, it's partially covered with the final x-ray from that day of surgery. And so that patient heals for a number of months and comes back, and you can see kind of in the left side, our final outcome. And then I also have just a retracted view, so we can see that the tissue is well maintained, the free gingival margin, the papillae, everything ended up pretty ideal. And obviously this patient was incredibly happy with the outcome. This from initial exam to time of surgery was 4 days. And so to be able to do this with this much precision, this much accuracy, without having to make the impression, send it to the guide, get a lab fabricated, we're able to do this level of dentistry for patients on a very abbreviated time crunch. And that's something navigation allows us to do that just hadn't been available previously. So that's one of the cases, one of the indications, and one of the reasons that we like navigated surgery in our practice. And I think it just serves as a nice, I guess, introduction to what we'll be talking about on the 5th.
That's fabulous. One quick question. The avulsion, did that lead to a fracture of the labiocortical plate?
It actually, it was intact. It was still attached to the periosteum. I did feel like when I pushed on it, there was some give. So I believe there was probably a green stick fracture, but the blood supply was still intact and it wasn't highly mobile. So we're able, by keeping the implant away from that plate, minimizing pressure on it, we're able to hold on to all of that.
That's great. So the take-home message that I think is most dramatic is always train the anterior tissue, avoiding any loss of bundle bone, and always use dynamic navigation. Is that how it works? That was my bad attempt at humor. In any case, listen, I really appreciate you taking the time to do this. If I'm not mistaken, you're on holidays, right? You're on vacation?
Well, yeah, I'm about to take off and head over to Rome to enjoy the meeting.
Well, I'm sorry that you have to do that. I realize it's an imposition, but nonetheless, have a wonderful time, enjoy, and really, thank you so much for doing it. It was marvelous. Thank you.
Thank you, Ken. Been an honor, been a pleasure.